You are the author of the upcoming book that's not out yet, The Lyme Solution, right?
Yes.
And so we're not going to talk about Lyme. We're going to just maybe touch on it a little bit. We'll talk about that. Maybe we'll do another show pretty soon about Lyme. But I thought we'd talk about, you wanted to talk about food sensitivities, food allergies. But before that, I want to talk about how we came to found you. I was listening to a podcast. It was a summit. It was a digestion summit. And I heard Dr. Amy Myers on there. And she was great. She was really cool. And so I told Kate, I said, Kate, you have to listen to this. This is really good. You know, she might be able to help you with your gut health issues and things like that. And then we tried to go see her, and then she was booked. And then her office told you to...
Her website.
Yeah.
Had a very, very small list of people that she personally recommended.
Yes.
And when I found one in California, I'm like, you got to be kidding me. And then I realized that Dr.
Irvine.
Ingles is Irvine/Connecticut.
Mm-hmm.
I cannot believe that. I just feel like the luckiest person ever.
Yeah, this is so cool.
Yeah,
Won the
no,
lottery.
I feel very fortunate. You know, Dr. Myers and I actually met at an autism conference a couple of years ago, and she was a keynote speaker there, and she was kind enough to come to my lecture on Lyme disease, and we just started talking afterwards and became very quick friends. And since then, you know, she actually started referring a lot of her Lyme patients my way because it wasn't something she was really doing a lot of. So we had a very nice collaborative relationship, co-managing patients, and it just kind of, you know, took off from there. In fact, I actually owe her a debt of gratitude. It's because of her that I've got this book on Lyme disease. You know, she really kind of lit the fire and actually put me in contact with her agent, and in turn, you know, was able to get me in contact with the right publishers. So
that's
a
awesome.
very fortuitous meeting for me, and so I'm very grateful. Yeah.
How many years ago was that? I'm just
That
curious.
was 2 years ago, actually, almost 2 years to the day. I'm actually going out this weekend to speak at the same conference, and I think it was 2 years. So
Wow, that's so cool.
Incredible.
Yeah, and what you've been doing with Kate has been helping her so much. It's been
that's good.
unbelievable. Yeah. Yeah, because
I've been struggling for many, many years, and this has been, I think my supplementation that I've done with Nikki Moses' work leading up to this was profound, but this is like, I plateaued, and now I'm like, next step. And I think it's, I'm curious about those immunity drops.
I want to ask you about those. What are those
are crazy.
immunity drops that you have, Kate?
Is that what they're called?
Well, yeah, I mean, it's technically called sublingual immunotherapy. And what's really kind of interesting is that it's nothing new. You know, sublingual immunotherapy, and for those listening, what that really means, sublingual means under the tongue, and immunotherapy is immune therapy. So the concept is really very much like doing allergy shots. It's just that we don't inject it. And it's strange that in the United States, it's still not an FDA-approved therapy for treating allergies, yet it's been used in Europe for over 40 years. In fact, in many countries in Europe, it's actually the primary way that they treat allergies before allergy shots. So allergy shots are actually the last resort. They prefer to do it because a lot of European countries are socialized medicine, so they're really about saving money. And what the research shows is that doing sublingual immunotherapy over allergy shots, it's about a quarter of the price.
Wow.
So it's significantly cheaper. But in this country, you know, we're a fee-for-service system, so you know, allergists get reimbursed by doing shots.
So those shots, what do they normally contain?
So the shots contain, after you've gone through different types of allergy testing, they can identify what triggers bother you, whether it's, ragweed or dust or cat dander. So they actually take very small dilute amounts of that substance, and that's what they're injecting you with.
Really?
So it seems sort of counterintuitive that giving you the thing that you're allergic to makes you better.
Isn't that what the same thing is with the immunotherapy too? Isn't that the same concept, or is it just sublingual?
It's exactly the same. So the concept of allergy shots and sublingual immunotherapy, it is exactly the same, is that we're giving you a small amount of the substance that makes you worse, but at the right concentration, it actually starts to modulate your immune system and turn off that allergic reaction.
Okay.
So again, you can do it for, if you're allergic to mold or pollen or animals, dust, any of those allergens actually can be turned off, using this technique. And the beauty of it is, when you go for allergy shots, you have to go every week initially to your allergist to get your shot. So, it's a time factor and convenience.
Yeah.
Where with sublingual immunotherapy, you do this at home. So it gives you a lot of control over the timing and the dose, and it can also be very, very patient specific. So where you might tolerate, 1 drop twice a day, someone else needs 2 drops twice a day, someone might need 3 drops a day. So we can really fine tune it to find out what that right amount is to modulate the immune system and really start turning off that reaction to the allergen.
I'm just curious, does it stretch out longer of a time period than people who go get the allergy shots? Is it
no,
it
actually,
it's
faster. When they've done studies comparing the two, they'll tell you allergy injections, regular allergy shots can be anywhere from 7 to 9 years of therapy. With sublingual, it's anywhere from 5 to 7. So you can shave a couple of years potentially off that therapy. And I think the difference is when you do sublingual drops, you do it every day.
Right.
So I think it's that constant reminder to the immune system that starts to shift, the way the immune system's reacting versus the allergy shot that you're getting weekly.
How is it different than homeopathy? It sounds pretty similar, no?
So homeopathy is different in that the substance that's being used is different than the allergen. So if you're allergic to ragweed, you're going to give ragweed. In homeopathy, the principle is based on like cures like, not like cures same. So we give a substance that at a full dilution might trigger a certain kind of reaction. And then when you dilute that out, it actually turns off that reaction. So, for example, there's a remedy in homeopathy for poison ivy called Rust toxicodendron or Rust tox.
Okay.
Although we don't usually give that remedy for poison ivy, but we might give it for someone that has a rash that looks like poison ivy. So you're trying to match symptom pictures versus giving just the actual substance.
Okay.
Plus the dilutions in homeopathy are far, far, far more dilute than what we use in immunotherapy. Immunotherapy is diluted anywhere from 1 to 10 up to about 1 to 80,000. And in homeopathy, you're in 1 to the millions, trillions, or even further. So
it almost gets into the frequency of the substance is no longer even there, and
right.
all
And
that.
in true homeopathy, if you remember from high school chemistry, this thing called Avogadro's number. This is that magic number where there's no substance left in; it's just resonant energy.
Yeah.
And most homeopathic remedies fall past that number, so there's no substance left. And this is sort of the controversy of homeopathy is that we can't prove the existence of a molecule, but this kind of gets into really, I guess, Einsteinian physics that matter's either created or destroyed. It just changes. So but homeopathy has a very long history of use, and I think for the critics out there, take a look at some of the animal studies. There's no placebo effect on animals,
right.
And they've done many studies on animals showing positive effects to homeopathy. So but there is a distinct difference between giving a homeopathic remedy versus doing either allergy shots or sublingual immunotherapy.
Have you ever worked with anyone that has had peanut allergies and have any kind of response to that? Because Kate's got that.
Yeah, for people that have the legitimate anaphylactic allergy, and maybe as a quick sidetrack to that, it's good to understand the difference between allergy, sensitivity, intolerance. We tend to throw the term food allergy around frequently because we understand what that means. But by strict definition, food allergy is the anaphylactic reaction that happens, or the very quick reaction that happens after you ingest a food.
Okay, so most people have sensitivities, then they think they have allergies.
Yeah, most people who eat a food and they don't feel well, they say, okay, I'm allergic to whatever the food is. But for someone who legitimately has a peanut allergy, their face swells, they can't breathe, it's very serious and potentially life-threatening. So I personally don't treat those kind of allergies in my practice just because I'm not equipped to have all the emergency stuff that could happen. There are allergists around the country that do that. We actually have an allergist up in Hartford, Connecticut that's been treating peanut allergy by actually giving small amounts of peanut and incrementally building the dose over time, and he's been very successful. And they do this in other parts of Europe and around the world, but in this country, I think most doctors are very gun-shy about trying it just for the litigious nature of how some people can be.
Their whole practice would be on the line.
It is a therapy that is used around the world, and it can be helpful. And
is that what NAET is?
NAET is a technique that was developed by a woman named Dr. Nambudaprad. She's a chiropractor actually here in the LA area, and it's a completely different technique. It's really kind of a combination of chiropractic acupuncture, and kinesiology.
Oh, sort of all combined into one system or something?
So, it uses muscle testing or kinesiology as a way to help identify what the body might be reacting to. And then the treatment, is they have you hold a vial of whatever the allergic substance is. Mm-hmm. They do an acupuncture treatment, and then there's a chiropractic technique that gets used. And then have you avoid the food for 24 hours afterwards. And then hopefully after that point, that sensitivity changes. So it's working on a very different level than certainly immunotherapy.
Yeah.
Is immunotherapy, I've seen stuff on going around Facebook and stuff, or is it becoming a cancer? It's getting its way into the cancer treatment world. I've seen immunotherapy for cancer treatment centers. And
what's
that about?
Immunotherapy gets used again. That's a very broad term because immune therapy can mean a lot of different things. So there's immune therapy as it relates to allergy, but when they talk about that, they're talking about immune therapy which is targeted towards cancer cells. So it's a really kind of a different mechanism than what we're doing in terms of trying to treat someone's allergy to dog or cat. Mm-hmm. In this case, they're trying to develop antibodies that will specifically target cancer cells. The problem with chemotherapy is that most drugs don't specifically target cancer cells, and therefore you get collateral damage and you damage healthy cells, healthy tissue. Mm-hmm. And that's where people get a lot of the side effects when they go through chemotherapy. Mm-hmm. So if you could develop a specific therapy that only targets cancer cells and leaves the healthy cells alone,
then
you need to take that and either
run for the hills.
Do something because you're going to be targeted probably.
Yeah.
If you can cure cancer.
I think that's what the researchers are really trying to do is, find a way to target that cancer cell. And of course, in cancer cells, what's interesting is that they genetically express different proteins. I mean, that part of becoming a cancer cell is that something in its DNA has gone haywire. Yeah. And that's why it starts to veer away from a normal cell line. Uh-huh. So what they try and do is identify, what's unique about that cancer cell that we can then target so that we're hitting the bad cell and not the good cell. Mm-hmm. But when you read about immunotherapy, you kind of have to look at the context of what they're referring to.
Yeah.
They've been doing immunotherapy for, diabetes and other chronic illnesses. Again, the target is different and the way it's being applied is different.
Okay. Uh-huh. Yeah, I looked on the, something that was a sponsored thing and it just looked like a regular medical cancer treatment center, but it said now we're using immunotherapy, and I was like, wonder how that's different than.
Well, there's a drug out there that's used in a lot of different type of cancers called Rituxan. Rituxan is it's a monoclonal antibody therapy, and it's given as an IV, infusion. And again, this antibody tries to target specific cancer cells.
Is that less damaging, do you think, than chemo?
Well, it's technically a type of chemotherapy.
Is it?
Is it less damaging? It's probably better tolerated than other cancer protocols out there.
Wow. But it's still a drug or, something like a pharmaceutical.
Yeah, and it still isn't as specific as I think any doctor or researcher would like. Okay. Again, we'd love to get to a point where, we know whatever drug's being given is really targeting, a colon cancer cell or a breast cancer cell or whatever that cell line happens to be.
Do you think that that's going to happen?
I think we'll get there? I think it's very possible. There's so much interesting work being done in the world of genetics and epigenetics now that I think if we can start to identify, as these genes get expressed, what has it done to change the cell? Mm-hmm. And when you can find those things that are very unique to the cell, it gives you some place to, really target your therapy. So I think we might see it in my lifetime.
It's weird because ever since Nixon declared the war on cancer in 1971, what kind of progress have we made? And I have to think that, I heard a doctor one time saying that he was speaking at different events and things and different, conferences and stuff. And he was saying that if there was no restriction from the FDA and the AMA and all this stuff, and natural doctors were able to actually collaborate with one another and to be able to come up with solutions and market them. And he was saying that his contention was that cancer would be a disease of the past relatively quickly if we're able to fund studies and do all this thing. But he was saying what they would do is after the conference was over, they would meet in a hotel room, 5 or 10 of the leading cancer doctors, natural cancer doctors, and share stories about what's going on and what's working and what's not working. And he was just extrapolating like, wow, if we were actually able to collaborate with one another publicly and to be able to do real research and to do real testing, cancer would be a thing of the past. And I have to think that he's probably right.
Well, I think in this country we have a lot of limitations on cancer research. I think, if you look at who's getting funded and the kind of research they're doing, I'm certainly not an expert in the cancer world, but as far as I understand from my friends who are, the amount of research certainly that goes into anything that might be considered alternative is very limited.
Yeah.
And I certainly, as a clinician, see lots of patients that are seeking alternatives and really have to go outside of the U.S. to find it, and whether they go to Mexico or Europe. But it's just a shame that we've gotten to that point that we sometimes drive people out of the country to find different therapies. I actually have a friend, he's been working with Congress actually, and he's in New York, to try and get a bill passed that's a right to try bill. That basically if you've got a disease that's very serious and there might not be good options available, that you have a right to try a therapy that might be very unconventional or not FDA approved.
So would that mean insurance would be involved in covering that?
People against lawsuits?
I don't know necessarily that it would be something that insurance would pay for, but at least it would give you the right to do it without having to worry about, or give your doctor the right to try something. If your doctor heard about something that's being used in Switzerland and it's not used here, hey, let's try it and see if it might help.
Okay, so the doctor could sort of
free him up a little.
Yeah. Kind of go outside the standard of care a little bit.
Yeah, so for both the patient and the doctor, it gives, a little bit more flexibility and freedom perhaps to try something that's been used elsewhere.
Wow.
And, and the doctors I know that treat cancer, they're very well read on what's going on around the world.
Yeah.
So, they're well aware of what's going on in Europe and Australia and other parts of the world, certainly for therapies that aren't utilized here very often.
Yeah.
I mean, if they're signing people up for studies, for clinical trials that they have no idea what it's going to do to somebody, I mean, you think that you'd have an option to try other things too. But
oh, you mean like the clinical studies that they do with
I've had
new
friends
drugs?
who've tried experimental stuff, and you're like, that's all anybody's guess too. So you don't know.
Yeah, and certainly, every big cancer center out there, MD Anderson, Dana-Farber, Fred Hutchinson, I mean, these guys are, obviously doing a lot of research, and there's always a clinical trial going on. But those trials tend to be very much just drug mediated.
Yeah.
And again, I think there's very little research that looks into other means, even something as simple as diet. And again,
God forbid they should look at the diet.
Yeah, and again, my colleagues who, their practices are very, much cancer involved. Diet's always a huge part. And I think, biologically it makes a lot of sense in terms of how your immune system functions. And if you're not eating good, healthy food, it's just harder for your immune system to do what you want it to do.
Right.
But, there's no profit to be made on that. So unfortunately, that does tend to spark a lot of research is, what's going to be the end result of that research. And it would be really nice to see, government and other entities start, putting money into looking at, diet, looking at, herbal therapy. Ironically, if you look at a lot of chemotherapy drugs, a lot of them come from herbs.
Their source origin is herbal based.
Yeah, one of the major, chemotherapy drugs used for breast cancer called Taxol is from the yew tree.
What's the yew tree?
It's an evergreen tree that grows up mostly in the Pacific Northwest.
And what do they do? They extract compounds from that?
Specific compound. Well, they that's where they originally discovered it. Now they make a synthetic version of it.
Okay.
Oh.
But that's where they, you can't patent a plant.
Yeah.
So you've got to make it different.
But they'll try.
Something patentable. But, this is where they discovered, that compound. And we've got, many examples of drugs that were derived from plants. I think one of the big drugs right now to treat high cholesterol, these statin drugs. Well, statin drugs originated from a food that they eat in China called red yeast rice.
Right.
And you can buy red yeast rice. And there was a really, kind of an interesting battle back in the early days when red yeast rice kind of came on the market. The company that was marketing it, Merck was the first drug company to discover, or make the chemical called Mevacor was the first statin drug back in 1987. And they actually sued the supplement company for patent infringement. Because red yeast rice contains 11 naturally occurring statin compounds. Merck took one of them, made it into a drug. and then tried to sue the company
crazy.
for patent infringement. And I think they won the initial suit, and then they lost on appeal. And now you've got many companies that make red yeast rice. But I think it's just a good example that we find a lot of things in nature that work really well, and then they try and find that one component, one ingredient that they can then turn into a drug and patent. But we've got many examples of things throughout nature. Back in the old days, treating heart disease, actually it's still used today, digitalis. Or digoxin. Digoxin's the drug, but it comes from digitalis, which is a plant.
Wow.
And we used to treat high blood pressure with an herb called Rauwolfia because it's got a compound called reserpine. Reserpine today still works beautifully to lower blood pressure.
And you can take it isolated by itself as the actual herb?
You can actually take the whole plant. And I use that in my practice. And people say, well, gosh, that's really old. Nobody's used that since the 40s. I'm like, well, that's true, but it worked. Right. It still works.
Right.
Yeah, it's just that they isolated it and then created a product around a pharmaceutical, and then no one remembers that it actually came from an actual herb.
Well, I think there's a natural cycle that when a new drug comes along, the old stuff just tends to go away, and it's not necessarily because it didn't work. It's just the new drug are sexier, and you feel like you're behind the times. If you're
there's marketing behind it.
I don't know if you remember when during the elections last year, Dr. Drew came out against Hillary Clinton's doctor that he was prescribing her Armour thyroid. And he says, well, nobody's used that in decades. This is old medicine.
Wow.
I'm like, Armour thyroid is actually one of the oldest, probably the oldest thyroid medicine. It's been around for 100 years, but it works.
Wow.
Yeah.
It wasn't like it stopped working or never worked.
Wow.
So
it's so funny though. It's like, we get a kick. I mean, even we do it. You eat a piece of licorice, you eat licorice your whole life, and then you go out in nature on a hike. There's a licorice plant, and you're like, this tastes just like licorice.
Yeah,
I mean,
I know,
it's
right?
one of those things, and you're blown away by it. And it's like, what are we?
Well, you take white willow bark.
I do take white willow
Yeah,
bark. I take a lot of things. Like
aspirin.
It's like you're surprised though that these things are like came from nature, even though you know it. It's weird. We're so removed from nature.
I know.
It's kind of sad.
Yeah, and again, I think when it comes to at least herbal medicine, you can go through cultures around the world, and even today, that still use herbal medicine as their primary form of medicine. And again, it's not that these substances don't work. I think part of the disagreement perhaps with the conventional medical community, they say, well, there's really no research on it, and in some cases that may be true, but if you've got a plant that's been around for hundreds or thousands of years, and it's been used by indigenous peoples for as long,
right?
The test of time actually says a lot about how well something works. Because the reality is, if it doesn't work, they would have stopped using it a long time ago.
Yeah,
right. And they certainly wouldn't be turning it into a drug.
Yeah,
I mean,
exactly.
But if you look again,
powerful.
who's funding research again?
Right.
Unless there's an endpoint that's going to be profitable, what's the point of spending all this money? Why spend several $1 million on a study on chamomile to see if it helps you relax? You can't patent it. You can't make a drug out of it. So, who cares? And I think, for the companies that would be interested in doing that, they just don't have the financial resources to fund that kind of study. So, we're left in a little bit of quandary on some of these plants that, there's just no financial impetus to do that kind of work. So, but I think, it's a little ignorant to ignore the historical use of these substances. I've heard this about Chinese medicine. Whether it's acupuncture, Chinese herbs. There's no good research. I'm like, how about 5 billion Chinese people over 5,000 years? I think that's a pretty,
no.
I think that's a pretty good longitudinal study, if you ask me.
That's only anecdotal. We can't have that.
The fact that they were able to develop really an entire system of medicine
that long ago, right?
It's at least 5,000 years.
It's crazy.
Old. And same thing in Indian, culture with Ayurvedic medicine. It's been around as long. And the fact that again, it's an entire system of medicine, their own way of diagnosing people, evaluating people. And yet you still have a large group of people in those countries that use this as their primary source of medicine. And, look, there's times where, sometimes going for the new sexy stuff is the right thing to do. And, I think in modern times, it really is about that combination of, traditional medicine, conventional medicine. And I was told by a doctor that I respect a lot when I was a medical student, it's not about what you use, it's how you use it.
Okay.
And that's always stuck with me. And again, I'm certainly not someone who's opposed to using medication when it's appropriate, but have you done the other lifestyle things first? Have you worked on diet? Have you worked on, getting good sleep? Have you done all these things that can really have a big impact on your health before reaching for the prescription pad?
Right.
And,
most people haven't.
Most people haven't. And as a doctor, it's very easy to grab that prescription pad. It's, if you work in a practice where you get 7 minutes with the patient, the time to go through these diet, lifestyle, and other factors.
There's not enough time.
It just takes a lot of time.
Yeah.
And, I feel bad for my allopathic counterparts that are in that model, because I think it's very hard to practice the kind of medicine you probably want to practice.
How long do you spend with patients?
Well, my new patient visits anywhere from an hour and a half to 2 hours. And my return patients, we usually spend at least a half hour. So
that's so crazy.
In naturopathic medicine, we're really about spending a lot of time with you to really, try and get the root of the problem.
So is it because the allopathic side has the insurance involved in their inability to make actually really any kind of money unless you see 30, 40 patients a day? Yep. Is that why they're spending 7 minutes with people?
That's exactly it. As insurance reimbursement rates have continued to drop, if the doctor's overhead stays the same or increases, the only way that you can start making a profit is by volume. And it's just do the math.
I mean, they have their debts. They have their school debt. Most doctors, they have, multiple homes, offices and employees.
If you're a practice of 4 doctors, you probably have 2 or 3 nurses. You probably have 3 or 4 admin people. You probably got 1 or 2 billers.
Office rent.
Your rent, your malpractice insurance. You start adding up
school debt.
Of course, you add that all up. It's a big nut to cover. And I don't think most doctors would necessarily choose this model. But the reality is that that's how it is if you really want to, succeed and keep your business floating. And look, I have a colleague in Connecticut who's a family practice doctor, and he's a solo practitioner, which is really rare these days.
A medical doctor?
He's an osteopathic doctor.
Okay.
But he actually has migrated away from the insurance model. He's now a direct pay. Mm-hmm. So it's basically like a club. You pay a membership fee, and then you pay a small copay every time you come in. But he's negotiated cash prices with all the labs, the imaging centers, to really keep the cost of healthcare down. But now that his overhead's gone down so much, it's actually easier for him to practice. And he even does home visits, which nobody does anymore.
Wow, that's old school, isn't it?
Yeah, it's given him the freedom to do that kind of work. And, he's been practicing about the same time I have. So I think he's probably 17, 18 years out. And just realized, the quality of life, the quality of care he felt like he was able to deliver kind of wasn't what he signed up for. So he just decided to shift models. And I think, you're seeing more and more healthcare providers, not just medical doctors, but move in that direction where you now get valued for your time. Mm-hmm. And insurance companies have never valued doctors' time.
No.
You don't get to bill because you spent 30 minutes with someone. Nowadays it's about how many boxes can you click on your electronic record, and that one-on-one with your doctors kind of faded away, and we're all kind of buried in our laptops, clicking boxes to meet the criteria that you have to meet. So the insurance company will give you, whatever money you're billing for that visit.
So when you're working with a patient, it's much more comprehensive. You're spending an hour and a half, 2 hours with the patient at their first visit. You're able to get to know them, their lifestyle, and so you're much more invested in their success. And I'm sure it's much more rewarding. I can't imagine how much of an actual emotional reward. Most doctors, when they get into that, they want to help people, and that's why they get into it, right? And so, but when you're spending 7 minutes writing a script for everything, how in your patients' lives can you get? So I'd imagine the natural side that you're on is much more rewarding. It's got to be.
Oh, absolutely. And, it really is about developing a partnership and a collaboration between the doctor and the patient. This is the way it used to be. Mm-hmm. I think there was a period there probably through maybe the 60s, 70s where, I'm the doctor, you're the patient, do what I tell you to do.
Right, yeah.
But back in the old days, your doctor got to know you, got to know your whole family, got to know everything that happened behind the scenes, what was going on in your personal life, because all of that makes a difference in your health.
It does.
And I think, being able to afford that that time to really get to know, the patient and your family and your kids, and really understand the dynamic in the world that you live in, it certainly is easier for me to be able to help you because I really starting to get you at your core level.
Yeah.
And again, I think every doctor has that intention and would love to get to that space, but it's just hard to do with short visits. So I love the ability to be able to sit down with someone and spend that time and really get to know them, and of course they get to know me as well. And and then we sit down together and say, hey, what's going to work for you? I've got these ideas, but let's be realistic about your lifestyle and your finances and work and everything else that, that's part of that mix. And, it really gives us the ability to, I think, give very personalized medicine. Yeah. And,
now that's, go ahead.
Oh, the best book I read on that. Do you know Dr. Alyssa Rankin?
I don't.
Have you read it? Okay.
Oh, she's great.
OBGYN that was going through this crisis of hating the 7 minutes, and she just bailed on it for a couple of years, came back and changed her whole model too. But I love her whole thing. She talks about getting your round table. Get people in your life that are co-creators, and it's like the very first step is picking people that are going to like bring life to you and help you, not just give you directions, give you things to do.
Like a team, right?
It's a whole team. But she talks about like literally get this round table around you, and if people aren't working out, fire them and find somebody that wants to spend the time. And it might cost you, but that's when you start to make major shifts with your health,
And absolutely. And certainly in my practice, I'm rarely the only person involved in someone's care. It usually is a team of whether it's me, their medical doctor, their osteopath, their acupuncturist, their chiropractor. None of us are experts at everything. And, I know what I'm good at and I know what I'm not good at. And I'm happy to refer to someone who can do something I can't do. But again, I think, having the time to sit down and go through that with patients, it just makes it easier. And then the referrals come easier. And then I think people really appreciate that, you're really looking out for their best interest and what's going to get them feeling better faster.
Yeah.
What are you seeing now? Like, you've been in this for over 20 years. I think it's 26 years it says in your bio, your official bio. But, in the recent 5 or 10 years, what are you seeing as far as like trends with people? Are you seeing anything that's coming up that a lot of people are dealing with, or maybe different age brackets that are having different concerns? Are you noticing any trends?
Or across the board? Is it like food allergies with all ages? Or
it seems like there's trends, doesn't it?
Well, I think when we talk about health trends, the thing that we still see rising is chronic illness. And the thing that scares me the most is seeing children with chronic diseases. And when you start looking at the statistics, more than 50% of the kids in this country have a chronic disease.
No.
Now, what would you mean chronic? Like asthma? Would that be part of it?
Chronic allergies, diabetes, things that we used to see in old people, we're now seeing in children. And that
digestive problems, is that a big one with kids? Digestive problems? Is that a big one?
Well, digestive problems certainly is part of that.
So you're seeing an upward trend of this?
We're seeing a ton of it. And every year it seems to get worse.
Wow.
We could probably have another 2-hour discussion of why that is. But, I'm an environmental medicine doctor. So, my interest is, what are all these things in the environment that's contributing to people's health? And we could certainly argue that our food quality is still not fantastic relative to the rest of the world in terms of the type of processing we do, the chemicals that get used, herbicides, pesticides,
soil quality,
genetically modified organisms, and so forth. Soil quality. But we also have a lot of other just, chemical exposure. And whether that comes through, mom when she's pregnant, which is a lot of it. We just still have a lot of industrial pollution and chemical use and
more chemicals, it seems like nowadays, right?
Yeah. And, the average American gets exposed to over 80,000 chemicals in a year.
80,000. And I read somewhere that there's like 27,000 new chemicals that are coming up every year. Does that sound right?
Probably is pretty close. And what's really scary is if you look at the EPA research in terms of the number of chemicals that have really been studied long term, we're just in the hundreds.
How do you make a new? I don't understand how they make a new chemical. How does that even work? I wonder. Is it just different chemicals they make into a product that have never been combined together before?
Sometimes, you can take an existing chemical and tweak it by a molecule, and now it's a new chemical.
So they can make new chemicals. That's weird.
Or you can just downright create a brand new chemical. I mean, there are, Dow and DuPont
they're
and
masters
Monsanto.
at it, right?
I mean, they hire, the brightest chemists in the world. I mean, think of Monsanto. If you're developing a pesticide and all of a sudden that pesticide's not working, well, now what?
Yeah.
So now you got to develop something
around.
else. And so, I mean, I'm sure they're in constant research to find, new herbicides, new pesticides that are going to work better, stronger, faster.
Well,
So-
how many thousands of chemicals are they finding in umbilical cord
That's over
blood
200, isn't it?
that they're passing on?
Like the umbilical cord blood?
Yeah, umbilical cord blood actually it's actually in the thousands.
Is it?
What's really interesting, to show how bad the chemical situation is or how long it's been around. If you remember DDT, you probably don't remember, we were all young then, but DDT was a pesticide that was being used. It was actually banned in 1972. So we have not used DDT in this country. However, the limitation is that we cannot use it in this country. Didn't say we can't manufacture it and sell it to the rest of the world.
Or what do we do with the existing DDT?
Ah.
Is that possible to use up the existing supply and then not manufacture and create more and use that?
Well, I think they had a period where you were allowed to use up what you had, if I remember right. But the thing is if you measure the fat of every single American, literally every single person, you will find a byproduct of DDT called DDE in everybody's fat, every single person. And we have not used this in 40 years.
How is that getting in the...
So part of that is that it's so persistent in the environment, it's still in the groundwater.
It just won't go
the
away.
half-life of a lot of these chemicals is decades, and I don't remember how long DDT was actually in use. The other thing though is, again, we sell it to Mexico.
Why not?
Where do you get all your produce in the wintertime?
Oh Lord.
Oh wow.
So we're selling it to other countries and then importing that food. So
that's why
still
it's
getting
staying.
exposure to these chemicals, even though we don't use it on our own crops. It's still being used around the world.
Wow.
Where are they making this stuff? Where are
Yeah.
these factories? I mean, are they all over the US?
They're all over the place. Yeah, they've got, hundreds of plants around the world that make these chemicals.
So I wonder, I was born in 75, and whatever year you were born, I wonder
It was
how...
before that.
It was... Well, I just wonder, how... If someone were able to actually do a count on the amount of chemicals we were exposed to as children, I wonder what that would be. Like, what would the number be compared to today? Like, would it be we were exposed to 200 chemicals and today it's 3,000? Or, is it that much of a difference, do you think?
It probably is. I've not looked at any research that, kind of counted the number of chemicals in the late 60s, early 70s to now. But we do know that number has significantly increased. And whether it's fivefold or tenfold, I don't know for sure. But it's significantly different.
Is that, do you think, the number one thing you're seeing with kids? Because you're saying, the
asthma and respiratory stuff and skin allergy.
You think it's the chemicals mostly?
I think it's a huge part of it. And, one of the scariest ones that's been getting a lot of press in the last handful of years is Roundup.
Yeah.
I actually had a chance to meet the lead researcher. He's an Italian scientist. Excuse me. He's a French scientist. He's got an Italian name.
Okay.
He's a French scientist. And he's the one that actually got the World Health Organization to label it as a possible carcinogen.
Really?
And, he was doing studies on rats, and he would inject them with Roundup, and they would get these massive tumors.
Wow.
But he lost all his funding. He lost his position at the university. They really lambasted him for publishing this research, and they tried to get him to retract it.
And this is created by Monsanto, right?
Monsanto
Roundup.
is the manufacturer
is
of
that
Roundup, yeah.
The glyphosates?
Glyphosate.
Is that part of all of that?
Yeah, and what his research found is, glyphosate is what's listed as the active ingredient. Are you sitting down for this?
Oh, no.
He found that the inert ingredients are 1,000 times more toxic than glyphosate, the active ingredient.
Because that's all we hear about is glyphosate, right?
And glyphosate is a problem, but he's showing that the inert ingredients, which they don't have to study, are actually more toxic than the glyphosate.
Why is that? Wow, that's nuts. And so what happened to him? Is he alive?
He's still around.
Is he still? He's not dead yet?
I think he travels with bodyguards, but he's still
travels
around.
with bodyguards and entourage.
He really, he risked a lot to, publish this research.
Wow. Thank God for him, right?
But it was really kind of, and the funny thing is, he is a molecular biologist. He's for genetically modified organisms. He says there is some benefit to it in certain circumstances. So he's not some fringe scientist out on a crusade. He just wanted to show what the science showed.
Wow.
And what it showed is that this chemical is very toxic.
So something I've been hearing from some of our guests recently is that they were saying that in terms of like children with autism, that I think it originally came from that lady, Stephanie Seneff. I'm sure
I was just going to mention her.
Yeah, she, I guess, was saying that the autism in her research isn't necessarily directly correlated to the vaccines, which there are, formaldehyde and mercury and all these chemicals in the vaccines that are leading to that. But what she was saying was that when the children are exposed to glyphosate and that reacts with the vaccine, it's that chemical reaction that's causing, she's saying, autism. And I know you do a lot of work with autism. Are you seeing that? Do you think that's right?
So Dr. Seneff's research is interesting. So, what's interesting is that she's a PhD computer scientist. Oh. She's not a medical person. She's a numbers person.
Okay.
And so she was looking at the rate at which autism was growing, and then she looked at the rate at which we were using glyphosate.
Okay.
And when she compared the two, the correlation was over 99%. And we've all heard this, correlation doesn't prove causation.
Right.
But 99% is
a high number.
It's pretty damning.
High.
Yeah.
Yeah. So, that's kind of been her, look at the incidence of autism as it relates to glyphosate, just because there is this very strong correlation. And in many ways, it makes a lot of sense because glyphosate is gotten into so many different food products. They did a study here in California maybe a year or two ago looking at wine. Oh. And even when they looked at organic wine, the organic wine had glyphosate in it because it's in the groundwater. So even though they're not spraying it over the top, it's coming up from underneath through the soil.
Oh my gosh, organic.
That's what Matt Blackburn or Jonathan Pantel.
Oh, was he saying that too?
Yeah, the chocolate guy, and he's like, he was sitting here telling us the same thing, and we're like, oh gosh, a long time ago.
Gosh.
Yeah, so the fact that the amount of glyphosate has gotten used and that has increased dramatically, and you've probably been told by some of your other speakers that we now use we being American farmers use glyphosate as a drying agent before they harvest wheat. So there's been an argument that the reason we're seeing so many gluten issues is because when you put the glyphosate on the wheat, that has altered the way that our body is reacting to gluten. Because again, if you go into the rest of the world, the incidence of gluten intolerance is far, far less than we see here in the United States.
Yeah.
But as far as I know, we're the only country that uses glyphosate. So they're using glyphosate as a pesticide, but they're also using it as a drying agent. As I understand it, you get a higher yield on your crop when you use it. So they're literally dousing the entire crop in this chemical just to dry it out.
Even organic wine.
Yeah,
well, that's
glyphosate was found even in
groundwater.
organic wine in California.
Okay, that's shady.
Wow.
So, now we come to this bigger question of how much of our organic food that's grown here is really organic.
Now, are we...
I know. That's a big deal for people, too, because a lot of people think it's a scam and way to make more money. And
the problem
validity to it.
I'm thinking about organic food is that organic is great, and obviously if you're going to pick up something at the grocery store, you might as well go for organic. But the issue that I'm seeing is like, okay, so what are we doing about all this chemtrails or tire dust or freeway dust or chemicals in the air that are falling down on these crops? And then also we're watering that with conventional tap water. So it's not like this biodynamic farming or any kind of this, way of taking care of the soil and feeding the water, diluted ocean water and the minerals and the rock dust and all this stuff.
Yeah.
So it's glyphosate's obviously coming up through the groundwater for wine, organic wine.
Right.
So
and probably all vegetables.
What would happen if we tested all of our vegetables? I wonder if they're organic vegetables.
What are we supposed to eat?
Yeah, we can't eat anything.
Well, the way that I frame it for people is that I think organic is still a better option. What it could be is that it's lower chemical.
Yeah.
Maybe it's not really no chemical.
Mm-hmm.
Yeah. Which is still better for you.
Right.
But, for years and years, I've had patients tell me when they travel to Europe, they eat foods they know bother them here. They eat it there, particularly the gluten and the dairy.
I've heard about
that.
that.
And they feel perfectly fine.
Yeah. Like Italy.
Yeah. What's the difference in what they're doing there versus what we're doing here?
Is there a test you can get to see your levels of glyphosate?
There is actually. Great Plains Labs actually offers a glyphosate test.
Really?
Yeah, I think it's $99, and
that'd be a good idea, wouldn't it?
Yeah.
Does it give you a number? Is it like a number scale?
Yeah,
of
it
how
actually
high you are?
it gives you a quantity. Now, what I will tell you is that every single person I've run it on has a positive level because it's in everything.
Yeah.
Okay.
Yeah.
So
some more than others. Are you surprised by some of the numbers, or is it all pretty high for people?
Well, it's all relative, I suppose, because glyphosate's just one of many chemicals they've been exposed to. The one thing it doesn't tell us is how much does that glyphosate level actually affect your health. Oh. Because we're exposed to so many chemicals, I think it would be naive to say that glyphosate is responsible for all of it.
Yeah.
But certainly, I think it reflects what your chemical load may be.
It's so tricky, isn't it? Because what number did you give about the inert chemicals that came along with glyphosate?
The inert ingredients in Roundup are his name is Eric Sertolini. Dr. Sertolini found that it was 1,000 times more toxic than the actual active ingredient glyphosate.
So when you have those chemicals, we don't even know what those are doing to kids, and
nope.
Wow.
All we know is they go around spraying stuff in our neighborhood, and we're like, get indoors. And then we will not let the dogs. The dogs are low to the ground by all that, and we're like, get them on the other side of the street. I mean, it's scary stuff.
Yeah. Well, I think the best thing you can do is, take care of your own. You have to watch out for your family, your kids, your own home environment. You control that as much as you can. Yeah. Beyond that,
I know.
You
have to live.
You find people where you can get a teachable, reachable moment and try and educate them. Unfortunately, I think in many cases it falls on deaf ears because for people who feel perfectly fine now,
right?
It doesn't seem that important. To stop using Roundup because they'd rather use it and not have to pull weeds than go back old school and get out the knife and start digging them out of the cracks of your sidewalk and things like that. So, we are a culture of convenience, and in that, anything that's going to make our life a little easier, at least perceived easier, generally takes precedence. Where cooking food from scratch is a lot of work.
Yeah, it is.
Where convenience meals are quick, and when you're a family of 4 or 5 and you come home at the end of the day and you're tired, look, I get it. But, unfortunately, what we've seen over the last, at least since I've been alive, the last 4, almost 5 decades of my life is, we've just gone to things that are quick and easy in every aspect of our life. And in that, I think, that's at least playing a part in, our health, both for children and adults. And I don't know that that's going to change anytime soon, unfortunately.
Yeah.
Are most people coming in the office with chronic illness?
Yeah, I'd say probably 70-75% of people I see, I'm doctor number 13 they've seen.
Really?
They've usually been to, many doctors, haven't either found the right answer or they've tried various treatments that just weren't, giving them the desired result. So I'm, the next person in line that, they're looking to try and figure out what's going on with them.
When you are getting results with people that is different than the 13 people they've tried before, what do you think's happening that you're doing that's different than... because you've helped me dramatically, and I'm like, why have I never come across this before? Are you testing a broader range of things and you're more open to seeing? I don't know, because I've been tested for so many specific things, but I've never been able to put it together. I'm just trying to figure out where do you start?
Yeah, I think a lot of it is just, looking at different things that, in most cases, it's just I'm looking at things that maybe other people just didn't look at. So, I'm not doing anything, magical or
you don't have a wand and
mysterious.
And a cape back there?
Yeah, it's just, I have kind of an interesting background. I was a clinical microbiologist before I was a doctor, so I worked in infectious diseases. So I know a lot about bugs, and so that's always kind of on my mind is, any kind of chronic infection as being an underlying cause. And then, I'm an environmentally medicine trained doctor, so I look a lot at allergies and sensitivities. So I do a lot of work looking at all the different things in the world that could potentially be a trigger. So, that combination's kind of afforded me, I think, a 30,000-foot view that maybe other providers don't have.
That's a good way to put that.
So
do you do stool tests with people?
Yeah. Are
they valuable?
They can be.
Yeah.
I did one. I sent it away.
Did you?
Yeah.
For Dr. Ingles? Mm-hmm. Oh, really?
Yeah.
Yeah.
Oh, that's right. That's right.
Stool test, again, you kind of have to take it all with a grain of salt. One stool sample is not necessarily reflective of every time you have a bowel movement.
Mm-hmm.
Right.
But, for people who have chronic gastrointestinal problems, it can definitely give you insight to, is there an imbalance in your gut ecology? Are you just not breaking down your food? Sometimes we find parasites, again. So it's one of these things that when you've got a good, solid positive, you feel pretty confident. But if you've got a negative, it doesn't exclude the possibility. And then for parasites, this is very much true. Looking for parasites is looking for a needle in a stack of needles.
Yeah.
I used to work as a parasitologist. I can remember sitting at the microscope with these slides, and you would go back and forth, and you're just trying to find any little, semblance of a parasite. And some of these, single cell amoebas, they get broken in half during the processing. You see half of a parasite, and it can be a little bit difficult.
Is it pretty safe to say that we all have
that's
parasites?
That's what I was going to ask.
Yeah.
Well, probably.
Most people,
I think right? Parasites, we tend to think of it being a third world problem.
Or an animal problem.
Or
humans would never have parasites.
Of course, we're not gross.
No. Feral cats, are loaded with parasites. Every vet knows that, but not us.
Yeah.
Well, it's interesting because if you look at countries that still have a high parasite load, if you look at most of Africa, the one thing that's really interesting is their incidence of autoimmune disease and allergy is almost non-existent.
Really?
Almost non-existent.
Allergies and food sensitivities, you said?
Autoimmune.
Or autoimmune disease.
Autoimmunity. You don't see lupus. You don't see rheumatoid arthritis. Why? And again, there has been some research into this, and what they found is that as we, through Industrial Revolution, become really more of a sterile society, we've eliminated, these beneficial parasites from our food supply. We want to just kill everything.
Yeah, that's
we
the
irradiate
nature.
food, we do this and that. So, these beneficial parasites really serve a role in modulating our immune system and certainly modulating the way our body even reacts to food. So I think even to a certain degree, the fact that we're seeing more food allergies, food sensitivities, food intolerances, probably to a certain degree is due to the lack of beneficial parasites that we used to get exposed to. In fact, I don't know if you know Dr. Sid Baker. He's out in Connecticut. Actually, he's in New York now. He's one of the pioneers in autism.
Thanks, Kate, for writing that down.
Yeah, he's been treating autistic children since I believe the 60s.
Oh, wow.
But one of the things that he talks a lot about is now reintroducing beneficial parasites like using a probiotic.
I've heard about that.
And I personally have taken beneficial parasites. I can attest to it. And
you're still here? You're still alive?
I'm still here. And, it's funny. I worked as a microbiologist, so I don't get creeped out by bugs at all. I'm not a germaphobe.
Yeah.
But when you look at the research, it's really fascinating. And there's a guy named Dr. William Parker at Duke University. He's a PhD, and he's actually been doing a lot of research with these beneficial parasites in multiple sclerosis.
Really?
And finding it really helps. Well, MS is an autoimmune disease, essentially. So he's finding that it's helping essentially, stop a lot of that autoimmune reaction. Mm-hmm. And I think what he's trying to figure out now is, well, how often, how much do you have to really take of this? But there is a specific parasite he's researching that's called Hymenopsis diminuata. And you'll also read about HDCs. So it's from the grain beetle, but itself is a rat tapeworm.
Oh.
So what would happen back in the old days when we would eat grains is that we would naturally ingest this. This organism doesn't cause infection in humans. It has no way to attach to the human colon and actually cause an infection. So it's really a transient, parasite.
Does it take up residence or does it come out?
Nope. It stays in your gut for up to about 3 weeks and then you just poop it out.
Okay.
Wow. Okay.
So they've been studying this specific organism, but again, back in the day, we would naturally ingest this just through our food, and then it didn't cause a problem for us. It passed through, but what they're finding is that it does have, pretty important immune modulating effects, and that's why, they're researching it for autoimmune disease. So
that's interesting.
I think we're going to find as time goes on that this is going to be one of those new therapies that really won't be so novel or weird. It'll probably be no different than taking, Lactobacillus acidophilus or Bifidobacter.
Because that's an active culture. It's a living thing.
It's a living bacteria. We forget that our microbiome in our gut is really made up of, lot of different things. I mean, we're talking, hundreds to thousands of different strains, trillions of organisms, but it really is a combination of bacteria, viruses, yeast, and parasites. We tend to focus on the bacteria a lot. You can buy a million probiotics that have bacteria, and we kind of ignore the rest of our microbiome.
I wonder if in the future there'll be, like, in the same way you can take pills, capsules of probiotics, I wonder if in the future there'll be capsules of parasites.
It's very possible. And
what do they call that? Hematosis or something? It's like taking the parasite. It's got a name. I forget what the name is. Yeah. Huh. But I wonder if that would happen.
Well, I think the newest thing that's coming, that's emerging, that seems to be very beneficial is fecal transplants.
Yeah, I was going to ask you about that.
Yeah, and if you think about it, when you're doing a fecal transplant, you are now taking that entirety of the microbiome that would, at least in theory, contain those bacteria, those viruses, those fungi, and those beneficial parasites. Now you're just transplanting the whole thing. Again, would that disrupt, do you think, other, the constituents? Like, in the same way, if you take a horse or a wolf here and then transplant it to Australia, it's going to mess up not just the direct interactions with it, but all the way down the line. It's going to create a whole separate issue. Do you think that it's doing that when people do fecal implants? Well, for the patients I've seen that have done the fecal transplants, I mean, it's been wildly successful.
Has it?
And I mean, I've rarely seen a case where it didn't work or really caused a problem. I think where we're at clinically, though, is that we're trying to figure out, who's the ideal donor?
Right.
How do you find someone that's never had antibiotics, that,
or pharmaceuticals and all that.
Something that would have disrupted the normal microbiome.
You have to go up to the hills of Tibet or something.
And, the problem is that our gut changes from the time we're infants to the time we're adults. Mm-hmm. So in theory, you would almost want to match your donor to your recipient based on age. If you've got a child, you would want a child of equal age because their microbiome is going to reflect a different mix of organisms than, a child would probably be less likely to have been exposed to these disrupting agents. Mm-hmm. But then again, their microbiome is not necessarily going to be what I should normally be having at my age.
Right.
And where do we find these ideal donors? And look, that may be what happens is that we have to go to, remote parts of the world to find people that really don't have exposure to these things.
Wow. I've heard of people.
Keep them in business.
I know, right? Give them a good job.
Create a whole new economy over there.
I've heard
wherever that is.
People talking about doing the same thing with breast milk with women who have never had antibiotics and never been exposed to chemicals or pharmaceuticals. Yeah. And then they're trying to now go, multiple generations of this. And so now you have a very healthy woman and she's producing breast milk. And then you can take that breast milk, culture it, and create a bacteria, that's applicable in, that you can take in tablet form or something like that.
That's so cool.
That would be interesting too. I mean, there's a lot of different ways of going about this.
Yeah, well, again, I think we've just scratched the surface on our microbiome, and we're just now beginning to understand exactly how complex it is, but also how important it is for, any chronic illness. You can go into PubMed, and find, search, microbiome and dementia and depression and obesity and insomnia.
Something always comes up.
We're just finding that, your gut is linked to just about every chronic illness that exists.
Wow.
And, it's kind of the running joke in naturopathic medicine. It's like, when in doubt, treat the gut. You're bound to hit something right.
I know, some symptom is going to clear up.
Exactly, and, but, the research is now really corroborating that it really is tied in to all of these different, chronic health problems. And if you can just get, the gut working better and get that balance of your microbiome, a lot of these chronic illnesses really start to reverse themselves.
So I've heard that in terms of the fecal transplant, the last I heard about it was that it would help a child with autism in terms of the child's symptoms for a couple weeks, and then they'd have to get another transplant. Is there been any update on that, or is that accurate?
Well, the way that most people, not just children with autism, but usually for people who are doing transplant, it's not just a one and done kind of thing. Yeah. You're usually getting multiple doses, and they've done.
But why is that though? Does it not roots? Does it not take? And is there something wrong with the host body where it doesn't take that?
Well, I think it's about the proportion that you're taking in from your donor relative to the volume of what's in your own body. And remember, these organisms are competitors.
So they're having
they're fighting.
As let's just say, for the sake of argument, that you've got 1 million organisms in your gut, and you take a fecal transplant that's only 100. Well, proportionally, that 100 competing against the million, it's going to do very little at a time. So you have to keep giving that 100 to eventually start to get enough of them that they're going to override the million.
So sometimes it's just a numbers issue.
I think it's just a numbers issue. And again, I think this is something that will get flushed out as they do more research. And what's the ideal quantity? How much poop do you put in people?
How do they do that?
Yeah. Is it expensive?
Well, right now it's all pretty much done in research facilities. So I don't know of anyone who has a commercially available,
in a back
and
alley
you can buy. I mean, I do have, I do know people who just do it on their own. They call their
Wow.
There are people who call their best friend who think things. I mean, I would not advise doing that.
Oh, wow.
There are people who
how do they do it? Like an enema kind of thing?
They did basically, there's a recipe you can find online of how to do your own, and they basically make it as an enema. But when you go to the research centers that are doing it, they've done it through freeze-dried capsules. They've done it through an NG tube where they feed a tube through your nose down through your stomach. They've done it through a colonoscopy.
So they've done all these different...
they've done all these different ways of delivering, the transplant to the recipient. And the beauty is they all seem to work.
Even through the stomach. The stomach acid doesn't have any...
Yeah, I have a patient there's a study ongoing at Yale where they've been looking at people with inflammatory bowel disease and doing fecal transplants, and they're using the freeze-dried capsules.
Really?
So the study recipients, get a certain number of capsules every day. Are they
suppositories or they're
No, they're oral capsules.
No way.
Yeah.
So you can't smell anything, taste anything.
I know.
That's an excellent question. And you know what? The funny thing is, he says you can't. He goes, you open up the little container they give you, and that particular study is a crossover trial. So every recipient's going to get the active poop, and everyone's going to get a placebo. They're just not going to know which one's which.
Okay.
But he went through the whole study. He's like, I couldn't tell the difference between the capsules. So whatever they did, they managed to mask.
They're great.
Mask the odor.
I wonder if this would be good for people that have just digestive issues. Do you think that, the information I've been exposed to about it is always in relation to autism. Yeah. But I wonder if there would be a benefit here for people reseeding. Because there's something a doctor was telling me recently that the average amount of different species, not the total number of bacteria, but he was saying the average amount of different species of bacteria in the human colon or digestive tract should be about 1,000. And he was saying in his studies that it's down to about 300 different species now. And so that's a 70% decrease. And so what he was saying was, it was really interesting. He was saying that back in the day when you would eat a steak or you would eat a banana, if you happened to eat too much of one of those things, your body would convert whatever that was, the bacteria would convert it to whatever your body needed. But now, since we don't have access to 70% of our bacteria, we can't eat a wide variety of food. And so he was saying that that's why you have a lot of people now with food intolerances or the inability to eat wide differences in their food, is because the bacteria is not there to convert it to what you actually need. Yeah. So
that's a great point. We could very well have lost the diversity in our microbiome, and I think it's hard because we're just more in recent years getting the technology that we can actually measure what the different strains are. There's a technology in the microbiology world that really only came out probably less than maybe 7 years ago. And I know the owner of one of the labs, and we were talking, and he was saying that, since they've implemented this technology, they're now identifying all these new strains that never came up on the old technology. Oh, really? So I think there's things that we haven't even discovered to even know. And, to add another layer of complication, a big part of your gut microbiome are types of bacteria called anaerobes. These are bacteria that basically need no oxygen to survive, and they do comprise a large part of our our normal flora. Well, we can't measure these through routine stool testing because as soon as they get exposed to oxygen, they die.
Mm-hmm.
So, a lot of times people do these stool tests and they've got all these chronic gastrointestinal problems and they say, well, my bacteria look fine. I'm like, well, you're only looking at half of them.
That's interesting.
We can't measure these anaerobes easily, and yet they comprise, again, a fair chunk of our normal microbiome.
So how do we know they're in there? Through autopsy or?
Well, we know they're in there, from other research. There is a way to do it. It's just not easy and it's not done routinely. When I worked in the hospital, we did anaerobic cultures all the time. So it's just that the way you handle the sample, the way you process it, it's all got to be done under very, very specific conditions to maintain the viability of the organism.
Yeah,
and just practically speaking, outside of a hospital setting, it's really hard to do.
It would take so much. It would be so expensive too.
And it would probably be cost prohibitive. So until we have a better technology to start measuring those guys, again, that's why I said I think we've really just scratched the surface of our understanding of our microbiome because we're not able to easily measure. And I think, as the DNA technology gets better, we will probably continue to identify more and more of those normal bugs. Mm-hmm. But as it stands now, we're better, but we're definitely not perfect yet.
It's funny because after doing, this is like 550 shows, and before this I had done, listened to so much different information, read books, and just exposed myself to so much information in the alternative health field. And it seems like we know so little. Of what's actually going on versus what we actually know. Yeah. And what we know, it seems like we know so, on one hand, we know so much. It's like all this stuff you're talking about and these new tests and microbiome and all this stuff. On one hand, we know so much, but compared to what's actually happening in someone's body, you're like a detective. You're trying to figure out what all these things are and how they interact with each other, with your patients. Compared to what's actually going on, I feel like we know so little.
Welcome to the party. It's true. I think, especially if you look at immunology, the immune system is something I will argue we really understand very little, right? On how it works and how all these cells and chemicals communicate with each other. And it's just so horribly complex. And we try to frame it out in a way that's sort of easy to understand. But the reality is that, again, I think we're in our infancy in the understanding of how the immune system really operates and how it works. And why do some people get more sick than others? Why are some people more disposed to autoimmunity than others? Mm-hmm. What is it that flips that switch that, seems to activate the immune system or in other cases, shut it off completely? Mm-hmm. Again, we know a lot, but that lot may be, just the tip of the iceberg.
Yeah, a lot of people on our show talk about like the stress connection, the spiritual connection with the family line and all this kind of stuff. that all plays a role as well. So now you have a whole separate world on top of the physical, this, spiritual, emotional side of everything. And my God.
And everybody's just so different.
Yeah, and everybody's just so different.
Times a billion people. This is crazy.
Well,
never going to see the same patient.
Exactly. Yeah. And I think, recognizing, our, in medicine, it's really easy if we can just put people in categories. It makes our job as doctors a little bit easier. Mm-hmm. But the reality is that we are very different. We're genetically different. We're chemically different. Yeah. I think even when you're looking at lab tests, we've got a normal range. Well, what's normal range?
There's no normal human.
You grab 100 people off the street and ask them if you're normal, and if you say yes, you draw your blood and you create a statistical deviation, and that's the reference range. Mm-hmm. Right. Why is it every lab has a different reference range for the same analyte?
Is that true?
Aren't you?
Is that true?
Oh yeah.
Oh, I didn't know.
Each lab has to establish their own reference range.
Is that part of what separates one lab from another? They're trying to make their. Is that kind of like a business thing, like how they're differentiating themselves?
Well, no, it's a legal, or it's a standard of care requirement for labs that each lab establish their own reference range for whatever they're measuring. Okay. And in theory, it's supposed to reflect differences in local populations. But if you think about, like cholesterol, why would cholesterol in San Juan Capistrano be different than New York City?
I know.
Right.
As far as I'm concerned, if you're human, now certainly we might expect to see differences between men and women on some things, or perhaps between adults and children. Mm-hmm. But by and large, and you'll see, if you compare, Quest and LabCorp or other reference labs, and for for anything. They're going to be close, but they're not necessarily going to be the same. And
so then do you have the differences between how the doctors interpret that? Because a lot of, like you were mentioning Dr. Natasha Winters, that was on our show recently, and she has a, is it Nasha?
Nasha.
Nasha, okay. She has different references and levels for what she's looking for. And so her levels are much different than the conventional natural alternative doctors. Her levels are way different. So then you have another layer, right, of interpreting that same information.
Well, you get into, again, maybe perhaps more of a philosophical question of, what is normal?
Yeah.
And if we now know that the large majority of this country is unhealthy, and yet we're including them in our normal pool.
Right, that's a tricky
thing. They
thing.
really aren't normal.
Right.
It's just they're common. And so, common doesn't mean normal. And I think, the unhealthier our society gets, as, every lab's developing their reference range, we're going to see these norms get kind of worse and worse. Mm-hmm. And, I don't know that any group has ever come out and really established what's optimal. And that's what we would really love to see. What is an optimal level?
But then how would you figure that too? What would be optimal? I mean, that's relative,
then you now have to get into finding truly a group of people who are healthy by whatever means you determine that, and start using them as the norm versus just random people off the street.
Yeah.
And I mean, look, when I worked
in Taco Bell and
when I worked in the lab, I worked in the lab for 5 years before going back to medical school, and literally I had my blood drawn every week to be used as a control.
No way.
Really?
I mean, I've got permanent holes in my arms from all the blood draws.
Oh my gosh.
But, we who worked in the lab, we were a lot of the controls. And are we normal? You hope so.
There's debate.
That's like, hey, are you sick today? No. Okay. Give me your arm. I'm going to draw your blood and you're going to be my negative control. And that's how a lot of it works.
Wow.
Man.
But, in the lab world, unfortunately, no one's really set a standard for whether it's a blood count or blood sugar, what is really ideal. And that's why a lot of us might on our own level have our range that we think is ideal based on our clinical experience, but certainly not something that's been well researched and across hundreds of thousands of people.
We talked to a doctor today, Dr. Thomas Cowan, and he was talking about the levels of cholesterol, and he was saying they're trying to get it now down to below 100. Then you have another guy, Dr. Hal Huggins, a couple years ago, and he was saying that the optimal range he's seeing is 222, and Dr. Cowan's talking about people, 250, 300 as optimal in his practice, but the conventional side is trying to get those numbers down below 100. And I mean, it's just like, what do you consider normal? That's just.
Well, and again, if we come back to the reference range, if you look at the reference range in the United States relative to the reference range in Europe, we are significantly lower than Europe.
Are we?
In terms of cholesterol?
Yeah.
Yeah.
Like, normal cholesterol, I think 220 is the European reference range for total cholesterol.
Oh, really?
And LDL, bad cholesterol, I think is 160 or 140.
Wow.
And then, here they want your bad cholesterol under 100. They want your total cholesterol under 200.
Yeah.
So it's almost like if you make people feel like they're abnormal, you're more likely to go on medication. But again, I think looking at it from a global perspective on, what's the rest of the world doing, especially Europe, because, we're similar in so many ways.
Yeah.
And even since I've been from the time I started in the lab, I started in 1991, and I'd look at the reference range. I mean, here they have come down over time. And they're like, why do we keep changing? And especially now that we've got all this emerging research that the lower your cholesterol is, your greater your risk of neurological disease, more Alzheimer's, more Parkinson's, and so forth. So we know that these fats are really important for your brain. And but I think, the cardiologists have sort of swung that pendulum too far the other direction. Though, we if we could get it down to zero, we'd be thrilled. Forgetting that cholesterol is the backbone for all your steroid hormones like testosterone and estrogen and progesterone. And
I've heard you can't even make those when it gets down to like 120 or below. You can't.
Yeah, when you start getting down below 120, I mean, I've seen people where they do start having hormone issues. Women will start having irregular periods, and young boys, they don't mature the way they should at the right time because they're not making enough testosterone. So it can definitely
if we can make a drug that will take it down to zero, then
We're
billionaire.
golden.
$1 trillion company.
Yeah, exactly. Yeah, it's I think it's one of these things that is not as well justified in science as they would probably lead you to believe. Again, giving some of the new research with this, now higher incidence of neurological problems.
And there's a lot of pressure put on from doctors to their patients to get on these statin drugs, and a lot of
a tremendous amount. And I mean, there's a
Yeah.
cardiologist here in town that we're friendly with, and we've had this conversation. And he really wants to kind of like move in a different direction, but he's been trained to do this. It's ingrained in him to just dole out the statin drugs, and we're going to remember they come with plenty of side effects too.
Yeah,
they are certainly not a panacea. But there is some research out there that people who were on statin drugs had lower overall cause mortality, which means they died from less other diseases. But we know that these drugs deplete the body of CoQ10, which is very important for energy metabolism and mitochondrial function. And I've rarely met a cardiologist that will have a patient supplement with CoQ10 while they're on a statin drug.
Really? That would be the first thing it seems like you would do.
And again, there's literally tons of research on this. This is not fringe medicine at all. But, most conventional doctors, unfortunately, just don't read.
Yeah, well,
they don't have time.
Yeah, they don't have time,
Got their 7 minutes, and then they go home and they're thrashed.
Yeah, they're tired.
My nutrition teacher when I was in medical school, he's a medical doctor named Alan Gaby, and
I've heard of him. Yeah, I've heard
Dr.
of him.
Gaby is really one of the foremost experts on nutritional medicine. In fact, he wrote a textbook on nutritional medicine about all the research on vitamins, nutrients, plus a list of all the conditions that these nutrients are indicated to be used for. And it's a textbook that's literally 4 inches thick.
Wow.
And he's got, I think, 25,000 references in that book.
Oh my gosh.
So when
What's
I hear
the
the
book called?
argument that there's, it's called Nutritional Medicine.
Is it available? People can buy
Yeah.
it? Oh,
Yeah.
nutritional medicine. Okay.
And-
Alan Gaby.
Yeah.
Okay.
Yeah, next time you're at the office, remind me, I'll show you.
Yeah.
Oh, cool.
Yeah.
But what's really interesting is, again, I'll get these arguments from other practitioners that there's no research on these nutrients. I'm like, well, here's proof that there is.
I've got 25,000 in this one book.
And Dr. Gaby's really kind of dedicated his life to doing all this research and summarizing it. And he has a newsletter, I believe, he sends out.
Cool.
Dr. Jonathan Wright, if you know him,
Oh,
he's
yeah,
Yeah.
we have.
so Dr. Wright and Dr. Gaby work together for many, many years.
Okay.
And they teach a seminar to doctors on nutritional medicine.
Okay.
But both of them have done, their own research into looking at these studies. And, sometimes they're small studies, sometimes they're old studies. But again, there is research out there. So to say that there's nothing out there is really just false.
Right. Yeah. So, Doc, do you see people? You see people on the East Coast and the West Coast. Do you see people via long distance internet, Skype, or anything like that?
Yeah, actually, I do work with people through what we now call telemedicine.
Okay.
And fortunately, some states have laws that permit that. And for people who can't travel for whatever reason, it's just a nice way to connect and get access. And, for the type of work I'm doing, it's actually very conducive because we talk a lot about diet and nutrition or herbs and things that actually works very well in this model.
So you're setting up individualized programs. There's no standard of care for you. But you're doing individualized programs for people like you're doing with Kate and
yeah, and the beauty of this, we live in 2017 in a digital age where video conferencing through various mediums is very accessible. So we can look face to face with each other, we can talk, get the same kind of history that we would normally do in a face to face visit. I mean, I always love seeing people in person. Again, it gives us a chance to connect on a different level. But
Right.
I work with a lot of autistic kids around the country. Putting an autistic child on a plane is very challenging.
yeah, I would
Yeah.
imagine.
And for a lot of reasons is difficult. So this at least gives us an opportunity to work together without the struggles of having to deal with the plane ride.
Sometimes people, some of our guests need to see the patients one time physically, and then they do the rest of their things. Do you require that at all, or can people do everything?
I don't, and it depends on the state that you're in. It so happens in the state of California that is not a requirement.
Okay.
You can actually do it through video conferencing, and that satisfies, there's sort of a legal, what establishes a doctor-patient relationship, and the state of California has said that video conferencing meets that need. So,
Cool.
Wow.
so that's the way.
That's
Can you
great.
order labs and tests for people
Yes.
if they're distance, and then you just go over them?
Yes. Yep.
It's a bummer that you can't test them with that machine.
Yeah.
Oh, the
well,
machine you
The
yeah. What is that machine you
What
use?
is it called?
Yeah, so it's well, the one of the things that we use in conjunction with all these other testing methods is that I do a thing called electrodermal screening. It's basically kind of like biofeedback. So it's just a different way of trying to evaluate how people react to different substances. So
not necessary, but helpful if people
it's just another tool in the tool bag to use. So we still do all the conventional testing that any medical doctor would do. It's just another thing to add in the bag of tools too.
You can never have enough tools, right?
So
well, I'm always looking at things that are going to give me information that's useful. And again, we get a lot through blood tests. We sometimes get it through imaging. Sometimes we get it through scratch testing, and sometimes we get it through this. So it's just, I think as much as we can put in our toolbox to help figure out what's going on with people, it just helps us hone in on what's going to be the right treatment. And ultimately that's what gets people better faster.
What's amazing is you've been working with Kate, and she has had sort of mysterious issues going on. We don't know what. For years, and she's finally seeing some relief working with you.
You haven't heard me complain for a while.
I know. I'm waiting for the complaint.
I haven't heard you complain for a month.
No, but you're feeling good. Your digestion's way better, right?
Well, that's good, because if you weren't getting better, I probably wouldn't be sitting here.
That's true. No, I'm really grateful. I feel like I did find the one thing that I'm like, okay, I'm making some progress. I feel like everything was helping, but now I'm actually getting better.
Well, and that's the reality for a lot of people, is that sometimes it's just that one little piece. You've done so many good things that have given you progress. Right. And, I know how it is with people too. If you've been feeling terrible for a long time, your goal is feeling completely free of all your symptoms. But if you only improve 25%, it's easy to minimize that progress. And even though it is progress, because you haven't crossed the finish line yet, you kind of have to keep it in perspective. So, anyone who's got a chronic illness, it's very realistic that whatever you're dealing with may take, months and sometimes years to completely clear the hurdle. But,
it's a long process.
Well, it took years to get there. So,
yeah. And I think, any practitioner you're working with should be able to give you a realistic, kind of long-term viewpoint of where you think things are going to go, what to expect. We're not always accurate. I have one woman I worked with Lyme disease in Australia, where I thought in a year, based on how she was feeling, she'd be over the hump. Well, she's much, much better, but we're still not over the hump, and it's now going on 2+ years.
And didn't you say that you were diagnosed with Lyme back in 2002, right?
Well, I wrote the book. The book I just finished on Lyme disease. I've had Lyme myself since 2002. So, I went through probably everything that everybody else with Lyme disease has gone through with antibiotics. And, when I was one of the few people that actually had classic Lyme disease. I had the headache, the joint pain, 105 fever, sweating, I had neuropathy. And I thought I had meningitis when I was in college. So I thought I had meningitis again, and I was getting ready to go to the hospital. And then I sort of found a big lesion on the back of my leg that I had not previously seen. Big bullseye rash, which is a classic sign of Lyme disease.
Right.
So I shuttled myself over to the walk-in clinic, and the nurse proceeds to ask me, "Oh, why are you here?" And I says, "I have Lyme disease." And she goes, "Well, how do you know?" And I'm like, "Well, the big bullseye on the rash on my leg's probably the dead giveaway." She's like, "Oh yeah, you got Lyme disease." Oh. So I was on antibiotics, and I did antibiotics for the 21 days of doxycycline, and after 4 days, I felt perfectly fine. I had no symptoms at all, but I happened to get infected 3 weeks before I was opening my practice. So, when I first opened, I was the doctor, the receptionist, the bookkeeper, the accountant. Everything. So, it was 12+ hour days. And after about 8 months, I started getting symptoms again. And so I went back on antibiotics, and it didn't do anything. And then I changed antibiotics, and it didn't do anything. And I went through this for about 8 or 9 months. And I got to the point where I was losing weight. I wasn't sleeping. My gut was a wreck. And I felt like a chemo patient. And I finally, I'd heard about a doctor in New York City named Dr. Zhang. He's a Chinese medical doctor.
How do you spell his name? Do you know?
Zhang.
Z-H-A-N-G. Okay.
Yeah, and he studied Chinese herbs and looked at them, and he treats a lot of Lyme disease and hepatitis C and HIV. Those are kind of his areas of expertise. And I had a couple of patients that had seen him that were very successful. So I went into New York City and saw him, and he started me on a regimen of Chinese herbs and acupuncture and really pulled me out of the weeds and got me to the point where I was like 75, 80% better.
Wow.
And I was on his program for probably 6 to 8 months. And then I kind of felt like I hit a little bit of a plateau. And then I switched over to another herbal protocol that Dr. Lee Cowden developed. And that actually did really well by me for, again, a little bit more. And then I was actually treated by a homeopath I'd been studying with in Belgium. She was here in the United States, and she was kind enough to treat me, and she really got me over the hump completely.
Wow.
Using a homeopathic remedy.
What was her name?
Her name is Henny Hoodensmast.
Ooh, look at that. Easy for you
I was
to
about
say.
to write that down.
No, that's...
So she is she's Dutch by birth, but she's been living in Belgium for 30 plus years.
Okay.
And she's just outside of Brussels, but I will argue perhaps one of the best living homeopaths right now, and just, again, tons and tons of experience.
Wow.
She's seen everything that you can possibly imagine, and again, very successful as a homeopath. So
wow.
I was fortunate enough to be treated by her, and she really got me over the hump.
That's
and
amazing.
so I've gone through the ups and downs, and I've had moments where I've had flare-ups, due to highly stressful situations.
Mm-hmm.
So it's been an ongoing learning experience of what sets me off, what doesn't, what gets me better.
Right.
And it's sort of that cycle that many Lyme patients go through. So
kind
nothing
of
like a little
that
personal experience to give you an education
Yeah.
in it. But from that perspective, again, I was able to write this book really as much as a patient as a doctor.
So for those that are interested, I'll just hold this up to the camera. It's called The Lyme Solution, the 5-part plan. And it says here on the back, the definitive book on treating Lyme disease. So I think what we'll do, you said this is coming out in about 6 months.
Yeah, we're not due to launch until March 27th of next year. So we've got about 6 months before the book will be released.
Let's do another show on Lyme around the time that it comes out.
Yeah, that'd be great.
Yeah.
Yeah, that's a long discussion too.
Yeah, man,
that's
I
great.
imagine.
There's a lot to talk about with Lyme.
Yeah, jeez.
I mean, I know a handful. I mean, I have like 4 friends that have Lyme.
It's crazy.
Well,
huge.
I think, Lyme, much like autism, you probably know somebody who is either affected or knows someone who's affected, has a family member affected. It's so prevalent now.
Yeah.
So, it's the fastest growing epidemic of infectious diseases right now around the world.
Wow.
And, we're going to continue to see more and more of it.
That's amazing. So people want to get in contact with you. What's the best website for them?
So my website, it's just my name. It's Darin Ingles, DarinIngelsND, not MD, N as in Nancy, D.com.
Okay.
And so if they go onto my website, they can sign up. I actually give you a free ebook on my top 10 immune boosting recipes.
Oh, cool.
So if they want to sign up for our list, we'll send you that ebook. And then, we send out, informational newsletters. We're very active on social media, Instagram, Facebook. So we're always trying to put out, educational information that just helps people, live better, healthier lives.
Yeah, definitely.
Thank you
That's
for
what
all
it's
you're
about.
doing and for helping me as well. And
Oh, my pleasure.
anybody listening, hit up this guy.
Yeah. Yeah. Doing cool things.
Really cool things.
All right.
Thank
Thanks,
you.
Doc, for being on.
Hey, thanks for having me. This is great.
I really appreciate it.